And she's also Program Director for the UW Center for Law and Philosophy of Children. Thank you very much.
Sure. So, can everybody hear me? Can you see? Yeah, you're good. Very good. So thank you to Anju and Hetty and Karina and Alex for organizing everything here. I'm looking forward to the day. I want to say, although I'm not a historian, I feel like I'm going to be the person who takes us back a little bit because our topic is Legacies of Distrust. So it sort of follows on what Crystal said. We want to think about what trust is, why there's widespread distrust of the medical system, of medical researchers in particular, and then think about some strategies for rebuilding that trust. And I'll just say, when I was a grad student, so now a long time ago, I worked with an amazing bioethicist named Annette Dula, and she and I worked on a book that she had been putting together for a while, an edited book that ended up being called It Just Ain't Fair, The Ethics of Healthcare for African Americans. And this predated all the discussion about implicit bias, so we didn't have that language to work with. But I think it's sort of shocking, you look back at history to think, what were the conversations that were being had? But part of the conversation at the time was, is there an African American perspective on bioethics? Like, we had to have that question, which part of what the book was trying to do was say, yes, absolutely there is, because there's this shared history and a different kind of treatment that people get, and also rational distrust. And I think that's part of what I want to bring out today, is just the rationality of certain kinds of distrust given that history, and then what others who aren't part of that group, or even if they are, but are now representing the medical establishment, need to do in order to recognize that legacy of distrust. So, just to start thinking about legacies of distrust, we certainly have in health disparities research now more attention to health disparities, which is great, to a wide variety of factors, both outside the medical care facilities, right? So, social determinants of health, things like socioeconomic status, stressors, available nutrition, safety, gun control, policies, policing practices, all of these things clearly are going to contribute to health disparities. But we also have factors inside the system, like things that Janice was talking about earlier today, so implicit bias within clinical encounters, but also things that Crystal was saying, right, differential treatment between group members when they're coming in for care from the exact same position or the exact same physician's group. So more aggressive, maybe at the end of life, even though it's not clear that that's necessarily a better thing, and often very much less aggressive for people of color earlier in life. And a lot of these things are documented in the old unequal treatment report from the Institute of Medicine, but of course well beyond that as well. So we know that there are these disparities, but then part of what we want to think about is, in the background of the disparities research, what is the awareness of or interest in the legacy of distrust that continues, right, that gets maintained over time. And I think that legacy is often centered on Tuskegee, right? That's the most famous, most well-known example. And, in reading things that have been out more recently than when Annette and I were working, it is interesting just how Tuskegee stands in for something, but people actually don't know all the details, and they misreport them, even on big national public, television shows. And so, the men weren't infected with syphilis in order to do this, right? There are different reportings about exactly who was involved in setting it up, what their intentions were, right? I mean, it's actually a structural issue about the way things were organized. So it started in 1932, and people were trying to do something good at the time. And then, right, as time went on, in 1940, when penicillin is discovered, and then it was really kept from people who could have benefited from this. But Tuskegee stands in, right? That is why there is widespread distrust. But of course, that's just one of the most well-known cases. If you look back through history, the way slaves were used and experimented upon and mistreated, and then even post-slavery, where people were able to get their care, there were segregated hospitals, they were used in experimentation, used in demonstrations within medical schools. There were people's bodies who were dug up from graves, right, because people couldn't protect their graves, and then they were used for early cadaver practice. I mean, it's a long, long history. It's not Tuskegee that happened, in 1932 to 72. And a lot of these things, I think, get spelled out in great books like Vanessa Gamble's In the Shadow of Tuskegee, or this great piece from Randall called Slavery, Segregation, and Racism, Trusting the Healthcare System Ain't Always Easy. And it's about not just now, right, but this long trajectory of good reasons for distrust. And then it extends on, right, sometimes people think that it happened with Tuskegee, and then, right, that was the work. And it just keeps going on, right? There are many more reasons to continue this kind of distrust. And it sort of comes through the decades since then, right? So when Annette and I were working on the book, Krause and Quinn had done all this work with African-American communities in Baltimore about beliefs about AIDS and how it was created or, made to be a genocide for certain populations. And I think one of the interesting features there is that people who aren't part of those communities look at that claim and think it's paranoia, right? It's conspiracy. How can somebody possibly believe this? And that's not recognizing why that view might seem incredibly rational given the history and the legacy, right, of misuse and abuse through experimentation. And of course we have the Henrietta Lacks story more recently. I can just keep going on, but I'm not a historian, so we'll let that suffice. I even had more things. So there are always, in bioethics, which is my world, discussions about organ donation, right? We know that there are disparities in terms of who waits on the list for scarce organs longer. So there are regularly discussions about trying to implement systems where we either have presumed consent or where we have sort of a pay-to-play model where if you offer to donate your organs, right, should you be in a position where you're dead and they're able to take your organs, then you'd be more likely to be prioritized on the list, right? But that puts certain people in double jeopardy because if they're more likely to be on the list in the first place and they're more likely to have what I would call rational distrust of the healthcare system, they're unlikely to sign up for that list because of this worry that if I go in there, if I could be saved and somebody sees this, then I'm less likely to get the care I need, right? And I think there's just this disconnect because physicians will often think, but that's irrational, right? You wouldn't be offered lesser care. But that's not, again, recognizing the legitimacy of the distrust given this long history that's there. So, right, I think one of the worries is we're going to find researchers who say things like, I'm well-intentioned and you don't have reason to distrust me, so can I just show you what I'm doing and maybe we can get along, we can work this out and do whatever our research project is. What I want to say is the researcher is going to need to demonstrate trustworthiness, right, and to offer some credibility to the person that they're trying to work with in order to build trust. You can't just hear the refrain, which I think isn't often explicitly voiced, but is there in the background. Tuskegee happened a long time ago. I wasn't part of that. It was terrible. This is different, right? Sorry, it won't work. So we want to look back at these histories or this legacy of distrust. And here I think part of what I want to focus on is the importance of recognition. So in a lot of work about disparities, I think some of the focus has been on access to care, right? How do you make sure, given social determinants of health, and just given the difficulty of getting into the healthcare system, maybe now made more difficult, right, looking like it all the time, how do you make sure that people have access to the kinds of care that are important to preserve our health and well-being? But I also want, so distribution matters, right, when we talk about healthcare justice, but it's also important to look at what somebody like Nancy Fraser, a political theorist, would call justice as recognition, right? To hear what somebody who is meant to be a partner in some collaboration says and how their perspective may be different from the one that you're coming from, right, as a medical researcher or a clinician. And recognition, right, for her was about participatory parity, trying to make sure that people are represented, that they come to the table, not just be invited, right, into an academic setting to sit somewhere and not necessarily feel comfortable and know the language, but to make sure that people have an equal chance to express their views. Not just, again, to say them, but to have them appreciated and respected, right? And that's different because you can give somebody a chance to speak, but not actually listen, right? Or not do anything in response to it. And so it seems like what we need to start addressing this legacy of distrust is, first off, a recognition of the rationality of that distrust. And then, right, some recognition of differing perspectives and trying then to build a bridge to work together on how to address some of those systems. So this has to be moving away from the sort of worries and claims about, or charges of paranoia, to saying, I understand where you're coming from, and I can see why this makes sense given the way that systematically, right, and Tim will talk about this more, in policing, in the media, certain kinds of lives are devalued relative to other kinds of lives, and that's going to end up being true across the systems, even within the medical system. So how are we going to build trust? What does it mean to demonstrate trustworthiness? I want to go back to philosopher Annette Byer's work. She had trust and antitrust from some time ago, but I think she said this really well. And at the time, she noted that philosophers have too often likely focused on contracts, right? The social contract, on how autonomous individuals come together and we have, roughly equal power and we make agreements with each other and then abide by those agreements. But that doesn't recognize that trust has to underlie those kinds of agreements, even if we have contracts. And part of what she wants to say is people are actually so differently positioned that we can't think about trust. We can't think about contracts that make sense in light of these power asymmetries. So she says, trust requires us to make ourselves vulnerable to another, right? If we aren't vulnerable, then we don't need to trust anybody. So if you have a very clear contract with everything enumerated, you don't have a lot of reason to have to trust anymore. But if you are making yourself vulnerable, then that's what makes trust a requirement. And interestingly, trust involves significant discretionary power on the part of the trusted. So again, if you have a complete contract of what somebody needs to do, there isn't a lot of discretionary room. It's just, these are the enumerated things that you must do. And I think this happens within the medical setting, whether we're talking about clinical care or research, right? I offer my body, and I have to trust you to know what you're doing to treat me fairly. And I don't know the details of what that's going to look like necessarily myself. And you have this amazing discretionary power to use that trust in ways that you see fit. So I'm also in that trusting relationship, expecting competence from you, right, as the person I'm trusting. And in the philosopher's world, right, different sorts of things, but maybe something like goodwill. I expect goodwill from you toward me. I expect you to treat my interests as something valuable. And I think that's where, when we look at the legacies of distrust, we can see why there isn't optimism about you taking my interests seriously, right? Given what I've seen happening, given what I see currently happening around me, there's not going to be that kind of optimism. And so there can't be trust. There might be reliance, right, a lesser level. I have to get medical care, so I have to rely on you to do something, but I don't actually trust you, right? We don't have this right kind of relationship where I believe that you have goodwill toward me to do the things that I'm going to need you to do. And so I think, right, if we want to figure out how we go about restoring trust or demonstrating trustworthiness, it has to be about demonstrating that kind of goodwill, showing the possibility of building that relationship where I take your interests very seriously. Yes. And to do that, I won't go into detail, but I think in work that I've done with some of the people down at the medical center, with Colleen and Malia, who are in the audience, one thing in medical research is really thinking about power sharing. So thinking about CVPR, community-based participatory research, right? Trying to do things where I think what happens is the researcher is actually made vulnerable to the partner. Because if they don't want to do things, if they don't have the same sort of goodwill, the research just won't proceed. And that's uncomfortable, and people don't want to do it. And also, it's not just about their individual intentions or willingness, it's about the structural system around us, right? That getting tenure is going to be more difficult. Grants don't really support this kind of work. And so we have to work on changing that structure of medical research as well. But I think that's what really has to be done in order to start rebuilding trust so that we can change, right, this legacy of distrust and get to one of trusting relationships. I hand it to Tim.
Hello, everybody. Well, is this thing on?
Yes.
Okay, good. So to keep things brief, I've prepared a set of comments, but first I'll say that what I say is meant to be sort of an extension of what has been said before and sort of the bizarro converse version of what Sara has just said. Yeah, almost converse, I think so. So, sometimes we forget that people of color do not distrust the medical establishment simply on principle or simply on retellings of history alone. These reasons would be good enough to be wary during doctor's visits, but we must remember that it is simply the case that people of color are too often subject to injustices as soon as they enter the hospital, and tragedies befall people of color who call 911. So just as an undocumented immigrant faces the risk of ICE detainment or deportation at the hospital, just as Lucilo Molina did last year after an emergency open heart procedure, the children of undocumented immigrants will face condescension or outright contempt from medical professionals for their cultural differences. And just as black people face the risk of being the target of brutality every time they leave the house, we cannot trust emergency services to know the difference between situations that require medical care and situations that require a show of force, which are usually not at all, none. These scenarios, however, are framed in terms of how people of color mistrust the medical system, and solutions to the problem seem to come in the form of winning the trust of this constellation of communities. It seems to me, however, that the converse is more to the point. The medical system mistrusts people of color, and people of color simply do not want to be the subject of what I'll call irrational mistrust and denigration that ensues from it. This is its own legacy of distrust. Take, for example, how NYPD officer, it makes me shudder to say NYPD anymore, Daniel Pantaleo ignored Eric Garner's pleas that he could not breathe and continued to hold him in a chokehold. One can see shades of this treatment in 2006 meta-analysis of articles on pain management, and I believe this was mentioned earlier, that people of color are less likely to be taken seriously when they say they're in pain, and are less likely to receive adequate pain management when they request it. This is, at least in part, an epistemic problem, a problem with how we regard people of color as knowers. Within the medical system, there is a failure to recognize the testimonies of certain kinds of people, the colorful kind, and two, there is a move to argue against people with dissenting testimonies that do not buckle under social pressure. These moves are a kind of violence. So in her seminal piece, Tracking Epistemic Violence, Christy Dotson defines the titular term as the refusal, intentional or unintentional, and I want to emphasize how intentional it can be at times, of an audience to communicatively reciprocate a linguistic exchange owing to consistent forms of ignorance that harm other people. Dotson's goal was to uncover and track the ways that people of color are either one, coerced into smothering their own testimony out of worry that their testimony will not receive uptake, or two, discredited as knowers in the first place, and therefore quieted. I believe these kinds of violence are in play when people of color come into contact with the medical establishment. For example, it is a reliable, persistent, systemic ignorance that results in black children being disproportionately diagnosed with oppositional defiant disorder, or ODD, according to Nancy Potter, who was also a presenter at this very conference in 2012. So keeping the legacy alive. She argues in multiple venues that the diagnosis of ODD often encapsulates dismissive white interpretations of black behavior. ODD is characterized by, quote, the persistent stubbornness, resistance to directions, and unwillingness to compromise, give in, or negotiate with adults or peers. But what happens when stubbornness and resistance are justified? For children of color struggling with mental health problems, the word defiant is often the prelude to a lifetime of epistemic injustices that they have every right to resist. But any attempt to resist the charge of being defiant is itself a form of defiance, and therefore self-defeating. Children like these, children like I once was, and the person who dropped out of high school to go to college because of these features, are stuck between the indignity of docility and the relative dignity of defiance. This is a difficult decision to make. Many of us just walk the middle path. These kinds of charges against people of color seem to permeate medical practice. We've already seen from Janice and Crystal that varieties of studies suggest that white physicians consider their white patients more able to afford treatment, more likely to comply with medical advice, and more willing to make requests on their own behalf. These last two attitudes closely resemble the earlier mentioned double bind. How can a person of color make requests for themselves when it's possible that would make them seem less likely to comply with medical advice? What do you do? And if the medical system does not trust people of color to know what their needs are, to participate in medical treatment, or even to act rationally, then participation in medical research is just a pipe dream. My contact with medical research is through neural engineering, and that hard to pronounce center. Much of my own research deals in the moral and societal implications of deep brain stimulation. These are implanted systems that treat the symptoms, systems that treat the symptoms of motor disorders like Parkinson's and essential tremor by applying electrical current to specific areas of the brain. I conduct interviews with patients using these systems in order to determine what effect these devices have on their sense of self. But my patients so far are only white men, and I often wonder why. Moreover, many of my white colleagues have friends, family members, or acquaintances outside of academia that have at least heard of deep brain stimulation. This is usually not the case in my family. None of them have ever heard of neural stimulation before. It's no wonder why, though. I can hardly imagine a physician referring one of my family members to a neurologist. I hadn't even heard of the title neurologist until I came to the UW. And I certainly can't imagine a neurologist suggesting deep brain stimulation to one of my family members. So how can people of color ever come to trust the medical system if they're not even trusted enough to be given access to a significant portion of it? This is a challenge that I struggle with as I learn that my study will likely never have contact with people of color. So what are solutions to this? I can imagine solutions, but they require a great deal of introspective and structural work. First, practitioners and researchers, and from here on out I say we, because that's who's here, need to make themselves aware of their own mistrust of communities of color. Why leave it up to, why think of ourselves as reaching out to communities of color that mistrust us when we don't even trust them in the first place? I do not think participatory parity is even possible if we are not honest with ourselves about our prejudices. Second, we must recognize both the moral and epistemic value of having people of color as patients, study participants, colleagues, and argue for it with our colleagues, as our two previous speakers just did. And third, we must do the slow, arduous work of paying attention to the people that it is too easy to dismiss. This requires that we restructure our studies, rethink our clinical and academic practices, and most importantly, listening more than we speak. And that's it.